Hello, I'm Michael Pinsky, and this presentation is on how you can predict impending cardiorespiratory insufficiency in the ICU. And the way we do it is by looking at dynamic principles. Here are my conflicts of interest, and they relate to the fact that, in fact, this is exactly the things that we are doing at patented and at federal funding. This is exactly what we do, and it's 100% my conflicts. Okay. What we're looking for is patterns in the data, sort of like a picture of the night sky. This is the night sky taken over time. It hasn't changed the night sky, but if you're looking at dynamic changes, you get information which wasn't present from a single snapshot. You can use anomaly detections, classifications, regressions, or anything you want to do this, but the methods that are used use computer-based large data collection, and we call that machine learning, simply because we allow the system to figure out features that can then make us understand evolving patterns, which are highly predictive of specific events. Predicting reality, we did one of the things that we looked at was predicting tachycardia. And with our junior faculty, Ju Yoon, we used the MIMIC database, MIMIC2, and we looked for clinically relevant tachycardia, which we defined as greater than 130 beats a minute, lasting for more than 5 minutes with a density of tachycardia of greater than 10%. We used as our two machine learning classifiers, regularized logistic regression and random forest. We had 2,800 patients to look at, for which we identified 787 tachycardia episodes, and we had 707 control periods from opposite patients. Tachycardia patients needed more vasopressor support, had longer ICU, and increased mortality compared to the controls. In our analysis of classification, the random forest outperformed the logistic regression, and that's what we're going to show. Basically, these data show that if you look at heart rate, though a heart rate of 110 is tachycardia, a clear step up in the use of norepinephrine, ICU length of stay, and mortality occur with 130, and that's why we chose 130. Using our predictive model, we create features, and the features are made by the computer, not by us. And the two most important features that would predict um, the onset of tachycardia at 0, 10, 20, and 30 minutes before the event were primarily the entropy of the heart rate and the fast Fourier transform features of the heart rate signal itself. So these two things, which are readily available from the heart rate signal, were the most important things in this analysis. What we found was that if you looked at the cases, which are shown here in blue and the normal controls in red, that if any tachycardia was present, we could clearly identify them at least 90 minutes, if not several hours beforehand. More importantly, the first episode of tachycardia, which is clinically more relevant, we could identify at least 75 minutes beforehand. And thus, using this event, we can now run this on data in real time to give you a tachycardia alert that allow you to take care of your patient beforehand. As you probably know, the group from the Netherlands, using my algorithm for predicting hypotension, studied the use of this algorithm that is owned by Edwards Lifesciences now and tested it in 34 patients. Their algorithm says the patient is going to become hypotensive, meaning a mean arterial pressure less than 65, really soon. And so this is perfect if you're in the operating room and you're an anesthesiologist. Using this, they were able to markedly decrease the median time of hypotension from 32 minutes to 7 minutes, and they had no adverse events because of it. We hypothesized that we'd probably better in the ICU if we could predict hypotension long beforehand, because just knowing that a person's going to become hypotensive 2 minutes from now is probably not as relevant for the ICU population where we're not constantly standing on the bedside. So we defined hypotension as either a systolic blood pressure less than 90 or a mean arterial pressure less than 60 for 5 minutes within a 10-minute period. We use the random forest classifier and receiver operator characteristics, area under the curve, and precision recall characteristics. We were able to, in the MIMIC3 database, identify 1,300 patients and match them to 1,600 controls. And in all cases, our positive and negative predictive values were excellent. This paper is under a submission for publication. And what we're showing you here on the dotted lines is the total number of patients in each group. Cases now are in red and controls are now in green up above. And you can see that as we get closer and closer to the event in hours, from 4 hours out, there are more and more cases in which we had monitoring events to assess. What you can see is that clearly 90 minutes before the onset of clinically relevant hypotension, we have a highly predictive value with a very low false positive rate. Thus, we have a clinically relevant measurement of hypotension that clearly separates from the controls and is completely present at least 60 minutes beforehand, which is clinically appropriate because now you can do something for your patient. We then went to our animal models, and this is an example from our animal studies, which we've been doing for many years. On the top is the mean arterial pressure, and then from a baseline, we bleed the animal, hold them down for a while, and resuscitate them based on other studies unrelated to this. Our question here is, can we identify the onset of bleeding using various parameters so that we know what's going on? Because once you start bleeding an animal, they don't become hypotensive right away. It takes time. What we were able to do with the random forest classifier in the animals that we bled at 20 mLs a minute, which is fast, 5 mLs a minute, which is super slow, but not at all, you can see that from the time 0 up until 30 minutes afterwards, and at 10 minutes afterwards, there's no measurable physiologic effect of the bleeding starting. Yet we can clearly see that we can not only identify that these animals are losing volume compared to green, the control, but furthermore, we can tell you the rate of bleeding using the same approach. So what we then wanted to do was ask the question, what is the minimal data set we need to predict insufficiency? Because you can't measure everything on everybody at all times. And we refer to this approach as hemodynamic monitoring parsimony. What is the minimal number of primary input variables like vital signs, arterial waveform, ECG, plethysmograph, et cetera, and how often you need to see the data, every hour, every 10 minutes, beat to beat, or in waveform. And how long do you have to observe? An hour, 20 minutes, 20 seconds. So we formally tested this in a paper recently published in Anesthesia and Analgesia. And if we go to low frequency, and what we're looking at is the relationship between the false positive rate in log scale and time to detection of bleeding in minutes. And what we have on the different graphs are non-invasive monitoring, CVC, arterial pressure, pulmonary artery pressure plus CVC, or arterial pressure plus a VA catheter. And as you can see, if you don't have a baseline value for your subject, and you simply look at them at any time, none of the systems can identify bleeding very well until you're well past 10 minutes in a low frequency. This gets slightly better to beat, but where we really see the improvement in performance is with the high frequency waveform data, where we have a ability to identify patients with an 80% probability that they're bleeding in less than 1 in 100 false positives. That is an extremely good response rate, but I need to have I don't have a baseline. If I have a baseline, shown on the right, you can see that low frequency doesn't do badly, but beat to beat is pretty good and high frequency is better. The bottom line is that if you don't have a baseline to assess the patient, you're looking at them now, you need to have high frequency data to analyze it. If you have a baseline, which would be commonly seen in patients who are admitted for surgery because prior to induction of surgery is your baseline, then you can get away probably with beat to beat data and still get good prediction. For any given monitoring device or combination of devices, baseline reference improves performance. If increasing data density improves performance by increasing featurization, and you need about 5 minutes of sampling to get robust performance, though I didn't show you that data. So what we end up with at the end of the day is a monitor, which we call predicting instability, time, and treatment, PIT. And it took us a while to get PIT out of that. And what you have is on the top, the probability of the event, and on the bottom, the time to that event. And on the right side, it's what is the event due to? Is it due to cardiac problems, volume, or vasomotor tone? Below this, you actually see the graph of the various data in real time and a prediction in the bottom of exactly what's going to happen. And as you treat the patient, the probability of the event goes down and you run away from the time in which it is. To the extent that this is possible is quite real, and we expect that such monitoring devices will be available in the next few years clinically to be used, because this is, in fact, the future of hemodynamic monitoring, smart alarms. Thank you very much for your attention.